Norway is to the left, and where I work is where the red dot is. Patients with hemoglobin disorders are predominantly immigrants from endemic areas, but in Norway, with a long coastline and historical exchange of genes, some Norwegians do usually unknowingly carry HD genes. Treatment in Norway is much more fragmented, but we do have good guidelines that have been developed for both thalassemia and for sickle cell disease. And the patients are treated at specialist departments at regional hospitals. And I'm wondering, Ulf, whether your patients are not also treated at regional hospitals more than local.
Yes, the majority at the regional hospital, but some are treated at the local hospital depending on distances, geographical reasons.
Yeah, okay.
But then they come for regular checkups.
Yeah,
at
good.
The regional center.
Thalassemia patients in Norway are, as I said, mostly children in families who immigrated from endemic areas. Probably there is an overrepresentation of children with severe transfusion-dependent beta thalassemia, and treatment is regional specialist at a regional specialist pediatric department, while the adult patients usually are treated in hematology department. I can say that in my this small red area, it's a small region, but we have 5 thalassemia patients and 3 sickle cell patients. For thalassemia patients, it's important to have an extended blood group genotype before the first transfusion. If it's not done before, it may be done by molecular methods. Intermediate thalassemia does not need regular transfusions, so they pose a lesser problem than patients with severe transfusion-dependent beta thalassemia. They are to be transfused to a hemoglobin concentration of 9 to 10 grams per deciliter, and that is to suppress erythrocytosis. If you do that, you will have less thalassemic red cells. The best option for the patient is to have voluntary non-remunerated blood donation donors and to have buffer coat removed blood that is leukoreduced and genotype matched. That's, I think, we have in all of Scandinavia. To obtain this and actually give this to the patients, you need a close collaboration between the clinical departments and the blood center. At the blood center, we need to know when the patients present in order for us to be able to call the best donors. The blood bank should call matched donors to have blood that is less than 2 weeks old, preferably younger, and we do that to reduce risk of alloimmunization and also to reduce the iron overload. But there is a but. To find genotype matched blood is a challenge given a predominantly Caucasian blood donor population. For sickle cell, it's also there is important to have extended blood group genotype before the first transfusion. For sickle cell, the clinical severity is variable. Sickle cell hemoglobin has a low affinity for oxygen, and it is actually better to, because of the low affinity, it delivers better oxygen to tissues. Sickle cells causes blood to clot, and to avoid clotting, hemoglobin must not exceed 10 grams per deciliter. The higher viscosity you have in the blood, the more likely it is to clot. In patients, sickle patients, with severe chest symptom, sickle cells must be kept below 30%, and their hemoglobin around 12 grams per deciliter is better. Treatment of sickle cell is quite complicated, and it needs experienced hematology specialist. For sickle cell, risk of alloimmunization is high, and transfusion may be given more or less often as needed. In some patients, exchange transfusions are preferred. Probably it is an increasing amount of patients that actually get exchange transfusions. It is always important to keep blood viscosity low and avoid hemoglobin concentration higher than 10 to 12. So as opposed to thalassemia, where you should aim for a hemoglobin that is higher than 10, you in sickle cell need a lower hemoglobin concentration. Again, as for thalassemia, you need the best blood, and for that, again, good collaboration between clinical departments and the blood center, and the blood bank should again call matched donors to have young blood, and not the least for sickle cell disease, it's difficult to find precisely matched blood, as we have predominantly Caucasian blood donor population. African sickle cell patients are often Duffy A and B negative, which is not a blood group you have in Scandinavia. So we need more ethnic diverse blood donor population. For pyruvate kinase deficiency, it's very rare, even though it's less rare in Northern Europe, it's still rare, and with variable clinical severity. If they need regular transfusions, again, they should have extended genotyping before the first transfusion, and they also should have buffer coat removed, leukoreduced genotype matched cells. And again, you need to collaborate with the blood center to call matching donors to reduce risk of alloimmunization and iron overload. Conclusions and recommendations are that patients with hemoglobin disease are dependent on access to regular transfusions from safe donors. They should have transfusions to the recommended hemoglobin concentrations, no more, no less. Complications to regular transfusions over years will be alloimmunization, which can be reduced if you get well-matched blood. And the other risk is iron overload, which may be treated with iron chelators. And with the best possible blood products that are as fresh as possible and as matching as possible, fewer transfusions will be needed. To have the best match for the patients, it is still necessary to have donors from different ethnic groups, but still such donors are rare, especially in Norway, but probably also in Sweden and Denmark. Thank you for your attention.